If you're a woman over 50 and you're on Ozempic, Wegovy, Mounjaro or Zepbound, or you're seriously thinking about it, there's a number nobody mentioned to you at the pharmacy counter. In the studies, about 1 in 3 people on these drugs loses more than 5% of their muscle. Not just fat, muscle. And after 50, with your hormones already shifting, that's the kind of muscle your body does not give back easily. A paper published just last month, in April 2026, put real numbers on it, and almost no one is talking about what it means for women specifically. That April 2026 analysis followed more than 8,000 people on semaglutide and tirzepatide, and it measured body composition directly, not just the number on the scale. It found that roughly 34% lost more than 5% of their lean muscle mass, and that the stronger drug, tirzepatide, stripped about 2% more muscle than semaglutide over a year.
When I first went through this data, what struck me wasn't the muscle number on its own. It was how one-sided the conversation around these drugs has been. We hear 20% weight loss, heart protection, and those benefits are real. I'm not here to scare anyone off a medication that's helping them. But there are 6 specific risks that hit women over 50 harder than anyone else. And then there's a 7th, right at the end, that almost no one, not even most doctors, connects to these drugs. It's the one that can quietly undo the very protection they're supposed to give you. Here's why this matters more for you than for a 30-year-old man losing the same weight. Before menopause, estrogen quietly works in the background. It helps your muscles respond to protein, and it acts as a brake on the cells that break down bone. After menopause, that estrogen support drops away. So when a powerful drug suddenly cuts your appetite in half and the weight comes off fast, your body is doing it without the hormone that used to protect your muscle and your skeleton. That's the setup. The same medication that melts fat off a younger body can quietly take muscle and bone off yours faster and with a shorter window to recover it. So let me walk you through the 6 risks the research flags for women over 50 in the order they tend to show up. And stay through to the end, because number 7 is the one I almost left out, and it's the one I'd want my own mother to hear. The first risk is muscle, and it's first for a reason. It's the foundation everything else sits on. When these drugs shut down your appetite, most women don't just eat less. They eat less protein. And protein is the raw material your muscle is built from. The studies show this isn't a small effect. With longer use, lean mass loss climbed from around 1.5% up to 7% in the tirzepatide data. And among the women who lost the most weight overall, more than 20% of their body weight, close to 1 in 10 lost more than 5% of their lean muscle. Now, here's the part one find reassuring, because muscle loss is not a guarantee. In documented case series where women combined supervised resistance training with a higher protein intake, lean tissue wasn't just preserved in some cases, it went up, even as they lost nearly half their body fat. So the muscle loss isn't the drug poisoning your muscle directly. It's the undereating of protein riding along with the appetite suppression. Research suggests aiming for somewhere between 1.2 and 1.6 grams of protein per kilo of body weight, spread across the day, and that lifting something heavy a few times a week is the only signal that tells an estrogen-deprived body to hold on to muscle. That muscle question sets up the next one, because the same fast weight loss reaches all the way down to your skeleton. The second risk is one almost no one explains because the headline data looks confusing at first. In people with type 2 diabetes, GLP-1 drugs are actually associated with a lower risk of osteoporosis. One large study put the risk reduction around 30%, so you'd think bone is safe. But the picture flips for women using these drugs purely for weight loss without diabetes. In that group, the osteoporosis risk came out slightly higher than with other weight loss approaches. The reason is simple physics, and it has a name, Wolff's Law. Your bones are constantly adjusting to the load they carry. Your body weight is part of that load. When you drop weight quickly, the mechanical stress on your hips and spine drops with it, and your skeleton quietly remodels itself down to match, losing density, especially at the hip and the femoral neck. And this is where it gets personal for women over 50. After menopause, estrogen is no longer there to slow down the cells that break bone down. So you've got three forces stacking at once. Less weight pressing on the bone, no estrogen brake on bone breakdown, and often lower calcium and vitamin D because you're simply eating less. The metabolic perks of these drugs aren't enough to fully cancel that out. Studies suggest weight-bearing and resistance exercise is the main lever that keeps the skeleton in the game. Now, you might assume bone is the most visible change these drugs cause. It isn't. The next one shows up every time you look in the mirror. The third one gets dismissed as vanity, but it's actually a window into what rapid fat loss does to the structure of your tissue. So stay with the mechanism here. Ozempic face is real, and dermatologists have documented it carefully. When fat comes off fast, it doesn't just leave your waist. It leaves the deep fat pads in your cheeks, the buccal pad, the malar fat, the cushions that hold your face up. The problem is timing. The fat disappears in weeks. But your skin's collagen and elastin can't contract that fast, especially after 50 when you're already producing less of both. So you're left with hollowed cheeks, deeper folds, sagging along the jaw, and a gaunt, prematurely aged look. This isn't a fringe complaint. Between 2022 and 2025, searches related to this phenomenon jumped by over 4,600%, tracking right alongside a surge in requests for fillers and skin tightening procedures. What I keep noticing in the comments here is that women aren't told this trade-off exists before they start. They lose the weight they wanted and then feel blindsided by a face they don't recognize. Here's what's fascinating, and what most people never connect. The same loss of structural fat and slow-adapting tissue that hollows the face is happening invisibly elsewhere, including around an organ that women over 50 are already primed to have trouble with. Before I get to the next three, let me quickly anchor where we are. So far that's muscle, bone, and the face. Three things that come down to one theme: fast fat loss, on a body that's lost its estrogen buffer, changes more than your weight. The next three move into territory that can land you in an actual emergency room. And the seventh, at the very end, is the one that can affect women on hormone therapy without a single warning sign. Number 4 is the gallbladder, and women over 50 are already the highest risk group for gallstones to begin with. So these drugs are adding fuel to a fire that's often already smouldering. There are three things happening at once. First, GLP-1 quiets a hormone called CCK, the signal that normally tells your gallbladder to squeeze and empty, so the bile just sits there. Second, the drugs shift how your body handles bile, raising the cholesterol concentration in it. And third, rapid fat loss dumps a flood of cholesterol into that already stagnant bile until it thickens into sludge and then into stones. The numbers are not subtle. For symptomatic gallstones, researchers calculate what's called a number needed to harm. How many people you treat before one is harmed. For semaglutide, that figure is about 5.5. For liraglutide, it's around 3. That means in some of these drugs, gallbladder trouble isn't a rare footnote. It's something that happens to a meaningful share of users. This next one is the risk I hear about the least, and the one that catches the most women off guard because it has nothing to do with weight at all, and everything to do with a pill millions of women over 50 already take every single morning. Number 5 is one of my favorites to explain because it's so easy to miss and so easy to manage once you know it. An enormous number of women over 50 take levothyroxine for an underactive thyroid. It's one of the most common prescriptions in this age group. And the whole way GLP-1 drugs work is by slowing down how fast your stomach empties. That's the mechanism behind the appetite suppression. But here's the catch. When your stomach empties more slowly, that thyroid pill sits in your digestive tract longer, and more of it gets absorbed. The pharmacology shows that taking semaglutide alongside levothyroxine can raise your total thyroid hormone exposure by around 33%. So a dose that was perfectly stable for years can quietly tip you toward too much thyroid hormone, which shows up as a racing heart, anxiety, trouble sleeping, and that wired but tired feeling. The frustrating part is that a woman might blame all of that on the GLP-1 itself, or on menopause when it's actually her thyroid dose now running too high. This is exactly the kind of thing a careful clinician catches. Research points to checking your TSH every 6 to 8 weeks in those first months and adjusting the thyroid dose down if needed. It's not dangerous when it's monitored, it's dangerous when nobody's looking. And that brings us to the risk that almost everyone underestimates. Not what these drugs do while you're on them, but what your body does when you stop. The sixth risk is the rebound, and it's the one that reframes how to think about this entire decision. These drugs don't retrain your body. They hold a powerful brake on your appetite for exactly as long as you keep taking them. Let go of that brake, and the body's defense of its old weight comes roaring back. In the SURMOUNT-4 trial, among people who'd lost a meaningful amount on tirzepatide and were then switched to placebo, 82% regained more than a quarter of the weight they'd lost within a year. In the semaglutide extension data, people regained about 2/3 of their lost weight over the next couple of years. And it's not just the weight. The blood pressure, the blood sugar, the cholesterol, the improvements snap back too, in what researchers literally call metabolic whiplash. But here's the part that ties back to everything I've already told you. When the weight returns, fat comes back fast and muscle comes back slowly. So a woman who stops can end up with a worse body composition than before she started. More fat, less muscle, which is precisely the sarcopenic pattern that's hardest on a postmenopausal body. This is why the medical consensus has shifted to treating obesity as a long-term condition, like blood pressure, not a problem you fix in a few months and walk away from. And realistically, most people do walk away. In real-world data, nearly 65% of women using these drugs for weight loss without diabetes stopped within a year, most often because of cost. So those are the 6, but I told you there was a 7th, and I almost didn't include it. I almost didn't include this one. But the data is too clear to ignore, and it affects a specific group of women who have no way of knowing it's happening. If you're on hormone therapy after menopause and you take your progesterone as an oral pill, this is for you. Remember the mechanism. These drugs slow your stomach and change how oral medications are absorbed. The manufacturer's own pharmacology showed that a single dose of tirzepatide cut the peak blood level of an oral hormone by 55 to 66%, more than half. Now think about what oral progesterone is doing in your body. Its whole job is to protect the lining of your uterus from estrogen. Estrogen tells the lining to grow. Progesterone keeps that growth in check. If your progesterone is suddenly being half absorbed without anyone realizing it, you've got estrogen acting on that lining largely unopposed. And over time, that's the setup for the lining overgrowing, abnormal bleeding, and a higher long-term risk of endometrial cancer. Sit with the irony of that for a second. These drugs are associated with lower rates of several obesity-related cancers, including endometrial cancer. And yet, through this quiet absorption problem, they could raise that very risk in a woman on oral HRT who's doing everything right. This is the one that bothers me the most, because there's no symptom that flags it. The good news is the medical world caught this. In 2025, the British Menopause Society issued specific guidance that women on oral progesterone may need to temporarily double the dose when starting a GLP-1, and that switching to transdermal estrogen with either a progesterone-releasing IUD or another non-oral route sidesteps the absorption problem entirely. None of that is something to do on your own. It's a conversation to have with the doctor who manages your hormone therapy, ideally before you start one of these drugs, not after. So here's what I want to know from you, because it tells me how well this community is actually being protected. If you're on a GLP-1 right now, any of them, drop 2 things in the comments. First, roughly how many grams of protein you're getting on a normal day. And second, whether you've added any resistance or strength training since you started. Just a yes or no. I'm trying to get a real picture of how many of you were given a plan to protect your muscle and your bones, and how many were simply handed a prescription and sent home. The pattern in those answers tells me a lot, and it shapes what I cover next. Because here's the truth. Every one of these drugs works on one thing, your insulin. But your body warns you long before that, and almost every woman over 50 misses the sign. That's the video on screen now. Watch it next. Everything I've shared today is for educational purposes only. Please talk to your doctor before making any changes to your health routine, especially if you're on hormone therapy, thyroid medication, or any GLP-1 drug. These decisions are yours to make with a clinician who knows your history.